Hey everyone, and welcome to No More, a podcast that envisions life after trauma. My name is Mireia. I am the creator and host, and today's episode is one I've been looking forward to for a very long time. When I think about the mental health crisis, there are so many contributing factors. There are abusive people and behaviors and patterns. There are so many catalytic moments. However, one of the larger contributing factors as to why we are in a mental health crisis today is actually the healthcare system, which is wild to think about because you would think that healthcare would be inclusive of mental health. That's actually not the case, and that's not the history. Joining us today is John Kajander, a life science and business consultant for the healthcare industry of over 45 years. John has held executive titles from the former executive vice president of the Texas Medical Center, which is the largest medical center in the world, as well as the CEO of TEAR, the Institution for Rehabilitation and Research. He was also the director of the Texas Business Group on Health, which brought together 250 employers and insured 6 million lives. With clients all over Texas and across the world, John sits on the board of multiple organizations, including the National Business Coalition on Health and the Medical World America's Conference and Expositions, just to name a few. John has not only contributed to millions of lives through his work in the healthcare industry, but he has contributed greatly to the show as my mentor and, above all, as one of my closest friends. Hello, John Kajander. Welcome to No More.
Well, thank you very much for asking me to be there. Always great to talk to my favorite podcaster.
Well, I'm excited to have you on the show, not only because we're very good friends, but because today's episode is a conversation that we have spoken constantly about. Today, we are facing a mental health crisis that has compounded over multiple generations of untreated, undertreated, and mistreated trauma and mental disorders. And part of that is because of the social stigmas that surround invisible illnesses such as trauma and mental disorders. And part of that is because of the lack of resources and affordable and accessible care, mental health care within the healthcare system. And this was in part a lack of design by the healthcare system as a cottage industry. With your decades of experience in financing and business for healthcare, I wanted to better understand how we have arrived at the situation today and how, with the information that we now have, how we still have not actualized and incorporated mental health care into the healthcare system today. I believe that to better understand the situation that we're currently facing today, we need to understand the history of our financing of the American healthcare system. And I know that you and I have talked a lot about the origins of how hospitals were created, and originally they started as a place for people to go and die in comfort and peace. But with the advent of modern medicine, it has transformed into a place of healing and launched the development of doctors in the workplace and what you have referred to as the cottage industry. Could you please elaborate on its beginning developments for us?
I'll be happy to try to do so, and I'll try to do it in such a manner that it's not either boring to people or send us down many long and winding roads. You started out by talking about hospitals, for example, being a place where people went to die. That was very much the case. They performed what is now known as palliative care. They wanted these individuals who were injured, ill, with not great prospects of coming out the other end healthier and alive. They wanted to, I'll say, warehouse them in such a place where they can be treated with dignity and respect during their final moments of their lives. With the advent of some of the modern medicine techniques, things as revolutionary at the time, as simple as physicians and caregivers washing their hands between patients, learning that you shouldn't do such things as use leeches to take blood out of a patient, or other great innovations in modern medicine, including such things as sanitation, better sanitation systems. We began to see how individuals, once they were ill, could in fact heal. As more and more individuals recognize this calling, we'll say it's a calling, where they can become healers, we began to create medical schools in places where physicians, nurses, and other caregivers could learn. However, medicine is, as we have discussed before, a cottage industry, and it has been perhaps one of the world's largest cottage industries, meaning that it was not completely organized and that individual providers would treat individual patients one-on-one one-on-one basis. And the business grew up that way. And because there wasn't originally a financing mechanism that would allow for larger populations to be able to afford care, individual physicians, individual caregivers began to provide their services on a transactional basis. And that transactional basis was, if I did X for you, you would pay me Y. Or it could be, in a rural area, it might be a trade for agricultural or livestock products. In the cities, it was for cash, for money. But these systems developed, and because there was no central thought and process to finance healthcare on a broader basis, it became institutionalized in our country as a cottage industry.
But unlike other countries around the world, we continue to build a medical infrastructure that was based on transactional care. And that was also born out of the capitalist opportunity economy, where we didn't, as you said, we didn't create one single infrastructure for people to access healthcare. I'm curious to understand, at the time of its development in the early 1900s, how our social narratives around or backed by the American ideology shaped and impacted the earlier developments of the healthcare system so that it did remain a multi-source funded medical system.
Right. It was not by design, it was by happenstance. What we saw was, in the workplace, employers began to provide certain insurance products, first to lower their risk of losing productivity and for the employee losing income when an individual was ill or sick. And then eventually it got collectively bargained, where certain employers, through a third party, through an insurance company or so, would then begin to receive reimbursement for medical services that they received. By and large, or as medicine itself became more organized, physicians began to band together and have professional associations. Those professional associations were very concerned about losing autonomy. And they realized that the greater the financial clout that an institution or organization had, the greater possibility that they could influence how medicine is practiced became apparent. Therefore, throughout most of the development of financing systems for medicine in the United States, medical professionals have opposed the majority of them, by and large. Not all, but by and large. And it was because of the fear of loss of income, the loss of autonomy.
So how is it that other countries around the world were able to provide public financial systems for healthcare, and the US did not develop in the same route?
Well, I'm sure there's several reasons, and I'm not a great historian on this. But back in the early 1900s, around 1910, 1912, Teddy Roosevelt actually was the first president to propose a publicly financed healthcare reimbursement system for medicine. And what happened is it did not pass, but we began to see cracks where such programs began to develop. We saw it in the Franklin Delano Roosevelt administration. We saw it as Lyndon Baines Johnson and others began to propose more and more publicly financed systems. Well, an overhaul of a medical system to provide a centralized public funding. In one example, Medicare and Medicaid in the mid-1960s were created, and that covered individuals from a federal standpoint who were of age 65 and above, which was considered the retirement age, and for individuals who were poor and could not necessarily afford to get healthcare coverage. And that was done on a state level. The federal government would create an overall program, but it would be administered from state to state. Again, a lot of organized medicine opposed these, fearing the loss of revenue, the loss of autonomy. In the 1970s, further, we saw the creation of managed care organizations as employers began to come to grips with the fact that they were paying significantly more than other nations were and other areas were for healthcare. And the uneven financing system was creating inconsistencies in quality of care, inconsistencies in reimbursements for care, inconsistencies in access to care. So the Nixon administration actually proposed and passed regulations surrounding managed care and created an opportunity for organized health maintenance organizations to flourish in the United States as an alternative to central financing of healthcare services. Meanwhile, while other countries began to finance healthcare on a public basis, the United States began to utilize employers as ways to fund healthcare programs and services for their employees, more than just wage replacement or if somebody was injured or ill. It began to be collectively bargained. That happened because during World War II, while there were wage price freezes, the federal government said through the Taft-Hartley Acts and through some internal revenue rulings, employee benefits could be collectively bargained outside of the wage price freeze and would not be taxable to the individual, but tax deductible to the employer, which made it very financially efficient for employers to be providing those benefits because they could take the tax deduction and it wouldn't cost the employee anything for the value of that benefit or service.
But at the same time, you also had to be able to work, which means you had to be physically able and mentally able without any sort of disabilities, because we're still in the space of transactional care that has been set up from the beginning. So healthcare was accessible and provided if you were able to contribute to the workforce.
If you can, it was provided initially just to you and then later expanded to members of your family, but not always. And you're right, the type of reimbursements that were created by these insurance products was transactional in nature. Transactional care works very well if you have an injury or a non-chronic illness. But if you are a chronic disease, if you have a mental health disorder, the types of services that you would have to have, the length of those services, the ability to measure your ability to get better is very difficult. And the way in which those programs and products were developed worked well on the transactional side, far less well on the mental behavioral health and the chronically ill side. And it continues to be a challenge to this day.
Because it's also measurable when you have a more critical or manageable illness or ailment, or if you break an arm, it's measurable in time. So you can not necessarily create a package, a medical package around it, but you can kind of have a start to finish understanding of the procedures that need to take place.
Most of the medical services that have been negotiated between physicians and the third-party providers of medical financing have been a fee-for-service or some modification of a fee-for-service. If somebody needs to go to therapy on a weekly basis for 6 years or needs X number of months of therapy for an eating disorder or whatever it may be, the incentive for the therapist is to keep treating because every time they treat, they get paid. At some point, Medicare changed how they did reimbursements and created something called a diagnostic related group, or a DRG, and they paid for what the average and estimate should be for that type of care. And what that did is it limited costs to care for chronic conditions. So it makes it particularly difficult in that type of system to figure out what is the right level of care to be providing, because the financing is driving the treatment plan.
Which still does create a costly and in a sense, can become wasteful because people are investing the cost for care within a 6 to 8 week period, let's give for example, and they still need treatment afterwards. And this is not something that is curable in terms of you put a band-aid on it or you get a specific medicine. So people are investing their time, energy, and money, and they are still being left undertreated.
That's very true. Very true. It is a real challenge. And again, a lot of it comes from history. And there's a great quote by Machiavelli, and I'll paraphrase it here, that says that there's nothing more difficult to do than change a system, because those who would benefit from the new processes and new regimes, you receive only their tepid support and the undying enmity of those that benefit from the old way of providing care or services.
It's kind of the conversation of, well, if I can do it, why can't they? The system is working for the majority, but now we are facing a mental health epidemic that is compounding and becoming exponentially worse, and people are not receiving the care, and it is affecting society. And that is in part due to history, because our systems, whether it's the healthcare system, the legal system, educational, or whatnot, is dictated and is built on directives that are driven by social narratives and ideologies.
Yeah.
And during the time in the mid 20th century, mental health was stigmatized. And if you were, it wasn't just that you were mentally or physically disabled and weren't able to work, it was you were stigmatized. There was negative, derogatory language and terminology used to describe you. It was an unknown. And so people created a narrative around this invisible ailment that they couldn't understand, creating lack of validation for what people were experiencing. And because of that narrative, the healthcare system, I would love for you to elaborate on this more, because you clearly understand the history greater than I do. But the healthcare system, in a way, implemented that narrative. And instead of incorporating the treatment for mental disorders, warehoused people in mental asylums and institutions where they were removed from society.
I actually think you described it very well. May not need any additional uh, any additional illumination from me, but it goes beyond the mid 1900s. It goes back probably as long as people have had mental health and mental issues. Not being able to put a band-aid on it or quote unquote fix it has always stigmatized individuals with mental health issues, mental disabilities. I think one of the really interesting things that happened was in the 1920s. The United States began looking at the quote unquote science of eugenics. And the idea there was you were going to make sure that genetically that only people who are acceptable should be able to breed going forward. And the idea was that they should sterilize people who have mental health issues, who were criminals and other undesirables. And over 65,000 Americans were sterilized. And in fact, eugenics became the basis of the master race theory that Hitler used in the 1940s when he came to power. Oliver Wendell Holmes, the Supreme Court judge, ruled against a family being who needed to be sterilized. I think it was 1927. The beginning of his opinion said, 3 generations of imbeciles is enough, with the idea that if somebody who has a mental health or behavioral health issues was allowed to reproduce, there's a greater risk of them producing people who are substandard as well, and therefore they needed to be institutionalized or sterilized or otherwise hidden from our society. The idea that we can create a stronger nation. One of the most horrible things that ever happened to our country was this science, pseudoscience of eugenics that really worked against individuals with mental and behavioral health issues. We really settled after they decided that maybe it wasn't best to be sterilizing all these Americans. We institutionalized them. We had significant infrastructure in mental health, as you call them, asylums, mental health hospitals, and we would put them away for years, if not decades, probably for the rest of their lives, quote unquote, treating them. And then during the end of the Carter and then the Reagan administrations, we began to deinstitutionalizing those individuals, but did not have a plan for their effective care. And the type of care they were receiving at the time was episodic. And by the way, individuals got reimbursed for those episodes of those individual instances of care. So you can see the history of mental health and mental disorders has really accumulated into a time and space now where we really have to figure out how to move going forward. We really need to change, in my opinion, how we think about treating individuals with mental health issues, with mental health disorders. And it needs to start by having a more common process for financing and moving people with chronic diseases, mental health issues, away from fees for service into a process which allows the care to be integrated with primary care and other care, as well as provide fair reimbursement to the care providers for what they do, but not be influenced by the lack of treatment or the overutilization of healthcare treatment.
So during the Reagan administration, when federal cuts were made, that resulted in the deinstitutionalization of people in mental asylums, there was an influx of homeless, and that inflated the mental health crisis.
It became more evident to individuals who were out in the community. These individuals used to be warehoused in a mental health hospital, or as you said, an asylum. And what happened is now they ended up on the streets. And you were walking down the streets of New York or Houston or wherever you lived, and all of a sudden there were many people who before you would have been invisible because they were warehoused somewhere. And now they're right in front of you. Created a culture of fear. There's fear, increase in crime. There was an increase of panhandling, things that were very uncomfortable to individuals. And quite frankly, if you look at the data, I spent probably a decade now working in a community here in Southwest Texas in San Antonio, looking at individuals who are underserved, including a large homeless population. When you look at the diagnoses, 2 out of every 3 individuals who received care in San Antonio on an annual basis who were homeless had at least a primary or a secondary diagnosis of mental health or behavioral health issues.
So going back to Oliver Wendell Holmes, how are we as the American people moving past the social stigmatization surrounding mental disorders and trauma?
Had a part of our community that was injured that we hadn't seen before, because before that they had died in the battlefield or had never made it back. A part of the culmination of that was that in the 1970s, Justin Dart, Lex Frieden, and others convinced President Bush 41 to support and to get the American with Disabilities Act passed, which provided the ability for individuals with disabilities, physical and mental, to have rights as American citizens, have the right to access to our community, to our economy, to jobs, to the ability to have social interactions with others, and to make sure that they can be integrated within the mainstream of our community where they had been institutionalized in the past. Again, one of the byproducts, unintended consequences of the deinstitutionalization of individuals in the 1970s and 80s during the Carter and Reagan administrations. These people were now out there. The question was, how do we do with them? George Bush and that group of medical researchers and professionals helped create the American with Disabilities Act. It has fundamentally changed our ability in our communities, legal structure, our housing, businesses, everything from ramps to being able to get over stairs. to be able to get into buildings. Individuals with disabilities, mental health disabilities, provide reasonable accommodation. Because of that, those individuals have become more integrated into our communities and the society than they had before. That has begun a real process of destigmatization of individuals with disabilities, in particular, people with mental health, behavioral health issues. It's one of the great pieces of social engineering and legislation that has ever happened in the United States, and other countries have passed similar legislations based on the United States American with Disabilities Act. Because of that, we're now having the conversation we're having, and that is individuals with trauma. How do we make sure that they continue to have access to appropriate mental health care when it's appropriate, make sure that they're further destigmatized? If those things wouldn't have happened, we wouldn't be having this conversation today.
And also to add, while people were being deinstitutionalized in the 70s and 80s, it wasn't until 1980 in the DSM-5 that PTSD, post-traumatic stress disorder, was finally recognized as a mental disorder, especially for veterans.
That's right. A lot of that was due to the fact that the reimbursement system didn't recognize it as a illness that needed to be treated professionally. People thought that they're shell shocked. You can't do anything. Lock them up, put them away, make sure they're not of harm to others. Now they found out that in fact it is treatable. It is a very challenging, but it is treatable, and a lot of that was because the federal government finally recognized the illness. You wanted to talk about this, the stigmatization of mental health in the military. The culture of American exceptionalism plays out in unique ways when it comes to mental and behavioral health. Not recognizing, again, in the example I gave you in San Antonio, that 2 out of every 3 people that is homeless likely has a mental or behavioral health disorder that probably impedes them in their ability to move forward with their life.
But yeah, we are a culture that is pull yourself up by the bootstraps. We celebrate people who overcome difficult times or traumatic experiences, and we pat them on the back and we celebrate them. And at the same time, we don't reward people who don't have the ability to overcome. And that's not to say that they don't have the innate ability within themselves to overcome. Mental disorders are wildly different than a physical ailment or a particular situation or circumstance that you could find yourself in, because it affects your mentality and it affects your overall well-being and perception of the world. But we do celebrate people who overcome and do not reward or provide the support system to help people overcome. So there is a hypocrisy that is built into our way of thinking surrounding mental health. And that in itself creates a vicious cycle, because not giving people the opportunity to break out of these circumstances, and you don't know how somebody has come into these circumstances, by not giving them the opportunity, you are leaving them at an even greater disadvantage.
I would agree with what you're saying. You see it all the time when somebody says, I don't give money to homeless because I'm just enabling them to stay homeless, as opposed to, I wonder what the background is of this individual who does not have a home. Is it a series of mental health, behavioral health disorders? What is it that is putting them on the street, and what can we do to help them?
It can also be the effect of, somebody loses their job, isn't capable of paying for their home, loses access to home, to healthcare, and then they develop mental illnesses and disorders, as well as coping mechanisms to help them cope with this great loss and grief. So much of this is perpetuated by this characterization of trauma and what trauma looks like. When we think of someone who is homeless or an alcoholic or an addict, we think of someone who is,
We think of them as being weak.
we think of them as, we think of people with mental disorders and various coping mechanisms as being mentally weak and defected. It does go back to Oliver Weldon
For
Holmes.
Wendell Holmes,
Oliver Wendell Holmes.
whose legal opinion on Buck versus Bell began with 3 generations of imbeciles is enough.
So as much as we have these disability acts, we still have a lot of work to do around destigmatizing and decharacterizing the way that we understand people with mental disorders. And in doing so and in recognizing their pain, we're actually able to recognize the effects of what cause and drive mental illnesses. And that affects society as a whole.
I would agree with that.
That also goes to show the importance of having I don't want to say necessarily proper information or the correct information, but being well informed of the reality of what trauma is, stamping out the social stigma surrounding it was actually what propelled the system to change. It was, oh, people are suffering. And on top of that, we can help people. This is treatable. It is manageable. It's not yet measurable because we're just beginning to understand it, but it does show that social ideologies drive the mechanisms of any given system. And with the ability to be open to the conversation, be well informed, people who are suffering are finally able to receive the care that they need. One of the things that I notice constantly in the conversations that I have with guests on the show or outside of the show is there is a large schism between individuals who experience trauma and develop mental disorders and individuals who don't experience trauma. And at the end of the day, it's validating people's experiences and diagnosis and disorders in order to help them receive the care that they need. And it's how do you integrate both sides of the conversation so that we can create an open dialogue that allows us to problem solve so that people can have more accessible care and integrate the cost and care of trauma into the system.
And integration of the cost and care into the system oftentimes means actually integrating the care.
Now that we've covered the history, the financing, as well as the social stigma surrounding mental health and behavioral health care concerns, as well as the social and cultural changes that have taken place over the last 100 years, leading us to the precipice that is both a mental health crisis and an opportunity to move forward. What do you envision those next steps will be?
Well, I think one of the things that is happening is we've seen a lot of the social stigma disappear. Some is still there, but we've seen some of it disappear. The other thing we have, one of the unintended consequences of our funding fractured system is it also becomes fertile ground for innovation. And I think we're beginning to see some of that when we see how care is now becoming more and more integrated. We're seeing on a federal funding level, we're seeing it in individual pockets of innovation in various communities. As long as we're beginning to see those types of innovations, I have great hope that we're going to begin to address how to provide that care in an effective and efficient manner, and we'll create financing systems and reimbursement systems that are congruent to providing that care.
And that's something that I really look forward to in discussing with you in the second part of our episode next week, as we explore and discuss incorporating the cost and care of trauma and what those opportunities look like when moving forward.
Great. I look forward to having that conversation with you.
Amazing. See you next week, John.
See you next week.
Hi, everyone. I hope you enjoyed the episode as much as John and I enjoyed putting it together for you. This has been a conversation that's been a long time in the making and a major conversation point for John and I over our friendship, especially with his experiences and the healthcare industry and my experiences with trauma. We talk a lot about how can we create accessible and affordable care for people with mental disorders. We can talk all we want about breaking the cycles and addressing abusive behaviors and patterns and actions. However, what's really crucial is also giving people the space to heal so that they can access that life after trauma. But part of that is having accessible care. And it is mind-boggling to understand that the healthcare industry is a major contribution as to why we are in a mental health care crisis. Now that we understand how we've gotten here, I'm really excited to continue the conversation with John in next week's episode, where we will be discussing how to incorporate for the cost and care of trauma. But in the meantime, I would really love to hear from all of you. As much as I enjoy putting these conversations together, so much of this is driven by a need to have a conversation with everybody else. Trauma isolates us, and I really want this podcast to be about community and connection and coming together and having a conversation. I'm curious to understand what your experiences have been with the healthcare system, whether you have had the ability to access care or not. How has that made you feel? How were you handled within the medical industry? Were you stigmatized? Were you shamed? Was there acceptance? Did you find that it was accessible in any way or easy to navigate? If you didn't experience that care, if you weren't able to access it, what are things that are helpful to you? Because as I'm getting to connect with these professionals along the way, this is a growing conversation that I get to have with them and build with them so that we can create this conversation and hopefully build momentum, or at least give people the idea and understanding that these things are possible so that they can be implemented. So you can keep up with the conversation on all major podcast platforms, including Spotify, iHeart, and Apple, or you can watch and subscribe on YouTube at nomore.podcast. And remember to connect, comment at nomore.podcast on Instagram, TikTok, Blue Sky, and Threads. I really mean it when I say I want to hear from you. It's important that we have this conversation collectively, because in order to break these cycles of trauma and envision that world after trauma, together, we have to say no more. See you guys next Tuesday.